Well, it's very exciting to be here for the first of these conferences, and in particular, enjoy the opportunity to be here and to meet with advocates really from all over the world. So before we begin, perhaps just to give myself a sense, how many in the audience are actual MPN patients themselves? Alrighty. How many have a loved one that's afflicted with an MPN? Alrighty. Well, great. Well, that gives us a great starting place. So coming here from Arizona in the U.S., I wish I almost had a joke slide about Donald Trump, but I too was as caught unaware as most in my country were, so we'll have to even try to develop something, because we really did not expect that to happen. So I'll kick off this session and agree that some of this will be review for many of you, but perhaps so that we start at a bit of a starting place, we've got a whole series, I think a total of 12 different talks on MPNs. We're able to get into things in great detail. But maybe to start with, first my disclosures. One can say that I have a lot of conflicts, or more accurately, that I've been involved with every drug that's been tested in MPNs so far. So as we think about MPNs, and we think about the theme of this whole weekend in terms of diseases of the blood, CLL, MPNs, etc. If we look back even over 100 years ago, these were diseases that were very incompletely understood. They were truly noticed by physicians from really just marked abnormalities in the number of blood cells and the consequences that could arise from those. These are tubes of blood. When you spin them down in a centrifuge, the blood cells go down to the bottom. The red blood cells at the bottom, in the middle are the white blood cells, and at the top is the plasma. And they'd be able to tell if there were too many white blood cells from really an excess in what we call that buffy coat, and depending upon what type of cell would lead to the definition of the type of disease that physicians thought was at play. As we start, and I'm reassured that I won't have to give all three talks. I knew my friends were close in behind me. But as we start and we look at the creation of blood, we start really with a stem cell in the bone marrow. From there, we move into the creation of cells that lead eventually down to platelets, red blood cells, and various types of white blood cells. With these, we had identified and called, based on strictly the increased number of cells, different types of chronic diseases of the blood. That's truly all that was understood. Too many platelets was essential thrombocythemia. Too many red blood cells, polycythemia vera. Too many white blood cells, crudely was called chronic myeloid leukemia. There were uncommon diseases of too many mast cells or basophils or eosinophils. There were even other diseases along with other white blood cells, such as chronic myelomonocytic leukemia. Now, we've come a long way since that, with many different aspects helping to refine how we understand these diseases. Now, these diseases can be even cousins of one another. As I share with patients the analogy, if we think about a state in the United States, that could be an illness. Let's say that state is, New York. Now, within New York, there are many counties. There's the city of New York. And the city of New York might be very different than someone who lives in rural New York. So again, as we think about different diseases, they may live in the same state, but depending upon where they live in that state, might have significant implications. Now, one thing that we clearly have learned that's a theme in all of the blood diseases are the issues of mutations. Now, what is a mutation? Well, DNA in our cells is really the recipe of how things in the body works. And a mutation fundamentally is a change in the DNA. It's a change in the recipe. And changes in the recipe can range from being important to not being important. If you have a cake and your recipe excludes sugar, my mother did this to us once. It was all frosted up. We had the cake. It was terrible. There was no sugar, but the cake baked. It looked fine, but it tasted terrible. Or if you forget the sugar altogether, the cake isn't even going to form. It's just going to be soup. So what's wrong with the recipe has a lot of importance. Next, it's a code. And depending upon the change in the code, you may understand what happens or may not. So if I spell Serbia with 2 B's, I might still understand that I meant Serbia. But if I started the word with Y and it's Yerbia, people may have no idea what I meant. So what type of mutation is important? Now, in MPNs, we really learned from our cousin disease of chronic myeloid leukemia that really was much more advanced in terms of its understanding. Indeed, it was one of the earliest blood diseases where there were changes in chromosomes that helped to identify that disease. Subsequently, that change in a chromosome was found to lead to a specific change in DNA, and that DNA created a protein that is not present in normal cells. So it was different, and that protein was the source of the problem. Finally, there were medicines developed to block that protein. So in a lot of ways, it's been the most logical development, and in many ways, other diseases of the blood, we've tried to follow the same pathway. Now, that pathway in MPNs is not yet fully understood, but we have many, many more pieces now than when we started. Another analogy I use for patients, imagine a jigsaw puzzle with 500 pieces. We have, I'd say, maybe 250, 300 of the pieces on the board. We don't have them all, so there are things that we understand and things that still are yet to be filled in. The JAK-STAT signaling is a key part of developing these diseases. Now, what these are is you can imagine different on-off switches in the cells that tell the cells when to grow and when to divide. So when we're making too many red blood cells, that's never by accident. Either there is a stimulus that tells our body to make too many, we live at high altitude, or there's something wrong in the DNA code making the body make more cells. The JAK2, and we'll get around to the specific mutations, is a key step between the signals that hit on the cell and downstream that will eventually lead for cells to grow and to divide. Now, that mutation, the JAK2 V617F, is a specific change in that sequence for the JAK2. That was identified back in 2005. Since then, there have been several other key mutations that have been found that have implications as to why we develop the disease and how they evolve. There are mutations such as calreticulin, the second most common mutation, only present in patients with myelofibrosis or ET, not present in polycythemia vera, not present if we see JAK2. We have other mutations that can develop in the JAK2 called the exon 12. We have mutations called MPL that are similarly in ET and P vera. And now we have increasingly other mutations that have implications in terms of how the disease behaves. And we'll get around to more of that discussion as we get into the other talks regarding predicting how an MPN is going to evolve. Now, as we look at the prevalence of these mutations, what I want you to get the sense of is that there's a few that are common and 3 that are key ones that we track. JAK2, CALR, and MPL are what we think in the field are the driver mutations. They're very key in terms of developing the illness. And there are increasingly numbers of other mutations that are not common. You'll see many of these. The percentage of patients with these are all very small numbers. However, in aggregate, they kind of build in, and those are additional pieces in that jigsaw puzzle. Some of them might be important. There's already been a few of these that have been found, if patients have them, might suggest that the disease is going to be more aggressive. So as Claire or Carlos are looking at the different mutation analysis on their patients, there are some of these that are going to catch their attention as being a concern, such as ASXO1, IDH1 and 2, P53, EZH2. There's some others we're not quite sure that they are important. There's one in this called DNMT3A. That's a fairly common one that is found as a consequence of aging, but not necessarily related to disease. So there's a few of these. If we just were to check a segment of the population that's 80 years of age, there's a certain percentage of folks that are going to have some of these that are not relevant. So again, we're still in the process of trying to figure out how these puzzle pieces fit together. In many different blood diseases and cancers, we increasingly are trying to look at different signatures of how someone behaves. So we're looking at these different patterns of mutations, but as John alluded to in his opening part, we know that patients can have a very, very different experience. We have some patients with polycythemia vera that are very ill with their disease, others in which it really has not affected them to a great degree. The same can be said with ET, the same can be said with myelofibrosis. I've had patients that have had myelofibrosis for 40 years with a little intervention, and there's others that are very ill from the very moment they have it. So what are the differences? So increasingly, physicians and scientists are looking at patterns of genes in maybe many thousands of genes, trying to identify are there patterns that suggest why people behave differently. You can imagine the science behind these things get complex very, very quickly and rely on very significant computational biology and other things to try to sort through the code of all of this information. This too is one of these parts that is very much in development. To give you an example of this, this is a cousin disease of MPNs. A lot of ways behaves like myelofibrosis, chronic myelomonocytic leukemia. And with this, if you take a group of patients, you could see the pattern of these individual mutation panels. At my institution, we now run a common panel that has 50 mutations. Some institutions have larger panels or smaller panels. But you can see each patient has a different pattern of how these different mutations, whether they're present or absent, and they may have important relevance in terms of predicting how the disease might behave. In the future, they may have relevance in terms of predicting therapy. At the moment, these patterns of mutations largely are investigational, with a few of them perhaps informing decisions regarding decisions around stem cell transplantation, but truly must be viewed as largely investigational. Now, other key things about the biology of MPNs are not only about the mutations. So the mutations are important, but they're not the whole piece of the story. There are many different individual aspects of having an MPN. My group has been very interested in trying to look into different aspects of the MPN burden. Different risk of vascular events, or patients that have had clots, some who never will. The different impact of low blood counts. In some people it's a big problem, and some people it is not. In some people it can be a sign to us that the disease is evolving. There's the issue of progression. We'll discuss this in a different talk, but again, this is one of the key concerns of MPN patients. As we've done survey research, the concern about progression is foremost in people's minds. The burden of the spleen. We'll get around to the spleen in a moment, but the spleen can be very enlarged and can be a source of discomfort, pain, or other difficulties. There are the symptoms themselves that can be a sign of the disease, as well as linked with the biology of the disease. And finally, there is the health of the individual. Indeed, an MPN is just a subset of an individual. An individual's overall health is composed of many things, including their baseline level of fitness, their health, the medications they take, their other illnesses, their family history. So one can never take one of these things in isolation. Our group certainly has identified that MPN patients have many symptoms. And we have now data in about 5,000 patients, 40 different countries, 15 different languages. And with that, we know that this pattern is very similar. I could tell you that a woman who has P. vera in Montevideo, Uruguay, has a similar experience to a man who has P. vera in Singapore. So the globalization of these diseases has given us much information regarding the similarity of what people face. Now, what do symptoms tell us about the biology of the disease? Really two components. One, there are, we believe, cytokine-driven symptoms related to inflammation and other difficulties that are from the biology of the disease. Second, there is an impact of having a chronic illness that impacts patients' mood in terms of anxiety, uncertainty, that clearly is a contributing factor as well. We saw in earlier clinical trials, red being increased, that cytokines, which are proteins that can be involved with inflammation and other processes, can be markedly elevated, in particular in myelofibrosis. And in this case, successful therapy with JAK inhibition decreased those cytokines, improved the symptoms. We've been able to look at these different patterns of cytokines and their relationship with the symptoms in the disease and see the tie-in in terms of the biology. Indeed, many of these proteins, they're involved with symptoms, they're involved with the biology of the disease. They might be involved with issues such as the progression, fibrosis, and other difficulties that we see. Again, they are incompletely understood, but are under investigation. Next, the spleen. The spleen has many different functions and normally sits up under the rib cage about the size of a human fist, or 100 to 300 grams. The spleen does many things, including filtering the blood, and it also acts as a part of the immune system trying to fight against infections. It's enlarged in MPNs, and we don't fully understand why, but we know part of it is an increase in what we call hematopoiesis. Cells circulate to the spleen, there they grow. We don't believe it's overly effective, but that is one of the mechanisms. It's also speculated that inflammation may be part of the enlarged spleen. When it is enlarged, it can cause symptoms, it can cause pain, it can lower the blood counts by holding on to too many cells. It clearly can shrink with therapy, and it's something we monitor. Next, blood clots and bleeding. A blood clot in the body is a normal process. When we have a cut, when we have an injury. When we speak of blood clots, particularly in MPNs, what we're fearing are blood clots that should not be occurring in normal circulation, whether they be in the arteries or in the veins. Clots in the arteries can include heart attack, stroke, these difficulties, but they can occur in area of the veins, such as in the legs or others. They are a risk across MPNs, more so in P-Vera and ET than MF, and there are many different contributors. But they are important as many of the goals of our therapy are in part to try to decrease this risk of blood clots. In addition, there is a risk of bleeding. It is ironic, as most of the time people think the counts are high, how could there be a risk of bleeding? The clotting I get, too many cells, they stick together. The bleeding is in part because our blood clotting system relies on both the cells, of which we have too many, but as well as circulating aspects of coagulation that have to hold those cells together. The body does not make any more of those circulating factors to compensate for the too many cells. So there is an imbalance. So if your platelet count is 3 million, markedly elevated, there's ironically a greater risk of bleeding than there is of clotting. Now, what about progression? Well, again, why do patients progress? We know patients with ET, PV, MF can progress to overt myelofibrosis. We believe that there are many aspects. Part of it might be inflammation and the microenvironment, the environment inside of the marrow in which the cells are growing, that may contribute to progressive myelofibrosis. The second is clonal progression, more mutations leading to evolution of the disease and progression toward acute myeloid leukemia. These are diseases that can be threatening even without progression. So trying to put this all together, an MPN patient has many things that we are tracking. We're tracking blood counts, we're tracking symptoms, we're tracking these issues of mutations, we're tracking risk of progression, we're tracking the individual, the comorbidities, and the other illnesses that they have. So they are complex diseases which we are trying to factor many things together to best understand how they affect the patient, as well as how we might best design treatments to assist them, as well as how we can help them in any way that we can. But we know one key thing that the patients need is really education. They need advocacy. They need a sense of community. Because one theme I hear repeatedly from patients with MPNs is that these are diseases that they are unfamiliar with. There's no family member that's had them. They're typically not on common television shows. There aren't a lot of famous people that have come out about their MPNs. So the work that all of you do, creating communities, whether they be physical or online or national, are a tremendous resource for these patients. And with that, I thank you.